Welcome to Inside 340B Report, an insightful conversation between 340B Report's editorial team on the key issues affecting the 340B drug discount program, the nation's second largest government drug program. Hello, and welcome to the latest episode of Inside 340B Report. I'm Ted Slafsky, publisher and CEO of 340B Report. Today, I'm joined by Shannon Young and Will Newton, who are associate editors and senior writers at 340B Report, as well as Bella Czajkowski, our national correspondent. Shannon, Will, and Bella, thanks for being here. How's everyone?
Good. Thanks for having me.
Yep. Very excited for the show. Thanks, Ted.
Same here.
We'll get right to the interview in a few seconds, but first I wanted to let our listeners know that we're pleased to offer a special discount to subscribe to 340B Report. First-time subscribers can receive a 25% discount. Go to the subscribe tab at 340breport.com and use coupon code podcast25. I know you'll find our news service to be a valuable investment. Thank you. It's been a couple of very busy weeks in the 340B world, like it always is. This has been particularly busy. We have new states that passed contract pharmacy access bills and other 340B related legislation. We have drug pricing talks that are starting to heat up in Washington. And we have seen important court cases where we've seen some important updates on some high-profile 340B related cases. Today, we're going to first dive into what's happening on the litigation front. Will, can you give us an update about what's going on with the lawsuits around the rebate models? I know there was an important hearing just recently that you certainly listened into here in Washington.
Yeah, definitely. So there have been some pretty key developments in the 340B rebate saga. And I think it's first sort of important to give a quick recap of what's happened to sort of get us to where we are right now. So as most of our listeners remember, last year at various points, 5 different drug manufacturers approached HRSA, an agency under the U.S. Health and Human Services Department, and said that they plan to convert upfront 340B discounts to post-purchase rebates, which would be a pretty significant change to how the programs largely work for the past few decades. HRSA responded and said, look, we believe the 340B statute says you cannot implement a 340B rebate without agency approval. And HRSA also threatened some pretty significant sanctions against those drug makers. In response, all 5 of those drug manufacturers sued HRSA and HHS. And we had the first really major oral argument hearing in those rebate cases just about a week ago at the end of April. So during that oral argument, 4 drug manufacturers, 4 of the 5 that sued over rebates, those being Eli Lilly, Bristol Myers Squibb, Sanofi, and Novartis, along with the drug industry vendor Calderos, all argued that they don't need HHS approval to implement rebates. HHS defended its position that the statute requires pre-approval, and an attorney for 340B Health, which is a hospital trade group that's intervening in the case, also joined the government defending its position. So several of us were closely listening and watching that hearing as it happens. And from listening to it, one thing that was pretty notable was that the federal district judge really was grilling both sides quite a bit there. So she was pressing drug industry attorneys repeatedly about the fact that, implementing a rebate would really upend how the program has worked for such a long time and could have potentially pretty bad consequences for covered entities. She also was pressing HHS and seemed pretty sympathetic to some drug industry concerns about the 340B program and specifically potential interactions between the 340B program and the IRA's Medicare drug price negotiation program. So during that hearing, the judge basically told HHS, asked, what is your timeline for giving us some more concrete information about when and under what circumstances, if ever, would you approve drug maker rebates? And so, in response to that, on May 2nd, HHS filed a document in the court that said it expects to be in a position to issue guidance within 30 days related to 340B rebates and 340B IRA interactions. So this is pretty significant and really has the potential to be a big bombshell in the 340B space, because this means that potentially, by the end of this month or early June, HHS will submit something concrete about whether and under what circumstances they might allow drug maker 340B rebates, if at all. It also means that the agency could potentially give some more concrete information on interactions between 340B and the IRA, which is something that both providers and the drug industry have been asking for. It's also possible, that HHS will continue to be pretty vague, and it only said it expects to be in a position. It didn't really give a lot of details of what the guidance would look like, so there is some uncertainty there. The drug industry responded to that and made it pretty clear that they were not at all satisfied with what HHS said. They said, quote, "It commits to nothing and, raises more questions than it answers." And they urged the judge to go ahead and rule on the rebate cases without waiting for HHS's guidance. So, with all of that said, I think something that we'll all be following very closely is, is this federal district judge going to wait for HHS to issue its guidance, or is she just going to go ahead and rule anyway? And then, if HHS does release this guidance, what will it look like? Will it have any details? Will they be a lot more clear on these things now that they sort of have a federal judge breathing down their neck asking for more information? So certainly some really big developments there that we'll all be very closely following.
Thanks for the update, Will. That's a really important case. And there was actually another important case that occurred in New York City, where you're based, Bella, having to do with the 340B program, but from a different angle. You recently attended a federal appeals court hearing in Manhattan, where there is a novel antitrust lawsuit against insulin drug makers going on. Can you tell us what you heard and why this case is so important?
Yeah, absolutely. So, as you mentioned last week, it was on May 2nd. I attended a rather packed oral argument in the Second Circuit Court of Appeals in Lower Manhattan in a case that is about whether four insulin drug makers, the major insulin drug makers, AstraZeneca, Eli Lilly, Novo Nordisk, and Sanofi, violated antitrust laws by announcing sort of similar, they differ in some ways, but by and large similar contract pharmacy restrictions over the course of a 4-month span. The drug makers, of course, say no, they didn't violate antitrust laws. They're all experiencing similar sort of financial losses due to what they call contract pharmacy abuses. So they came up with the policies independently, and they just so happened to be announced around the same time due to those similar financial pressures and losses. And this case was originally brought by a New York-based health center, Mosaic Health, and Central Virginia Health Services. And the case is on appeal after a lower court dismissed it in February of 2024, citing insufficient evidence for these antitrust allegations. So at the May 2nd oral arguments, the federal appeals judges, there was a panel of 3, they appeared a bit more sympathetic to the health center's arguments than the lower court did, and really kind of dug into whether the 4 insulin manufacturers could have announced those restrictions, contract pharmacy restrictions, just incidentally in that 4-month span, without conspiring to avoid the ultimate federal sanction, or I guess I should say one of the ultimate federal sanctions, which is exclusion from federal insurance markets. And the health centers reiterated their argument that they believe the drug makers, quote, held hands and announced the policies together, since they have, they called it a chokehold, but it is a near majority on the insulin market in the US in manufacturing. So it'll be interesting to see, if the federal appeals court sides with the health centers, the case could have major implications for how 340B covered entities can challenge drug prices in the future. and they don't have many avenues to do so now, which stems back in part to a 2011 Supreme Court decision. Ted, can you explain a little bit why that is?
Sure. So there was a really important U.S. Supreme Court decision, the Santa Clara case, AstraZeneca v. Santa Clara, which basically where the court decided that it is up to the federal government to enforce drug pricing disputes between covered entities and drug manufacturers, that the covered entities don't have a private right of action to challenge disputes over overcharges. The argument being that the government has a good system in place to allow these disputes to go through the typical process. Now, one could argue that the dispute process is not particularly effective. One could even argue that it's never been effective since it's been implemented and finally began being used a few years back. So the covered entities are really in not a good situation when it comes to challenging what they believe to be overcharges by drug companies. What makes this case interesting is that the insulin drug makers were sort of the leaders here when it came to placing restrictions in the contract pharmacy setting. 340B Health, my former organization, has also brought up that interesting development that a lot of these first drugs were insulin products made by some of the big drug makers. Drug makers say that they did not coordinate with each other. It'll be very, very interesting, and it would be a sort of a different way to approach the frustrations that the covered entity community have had in not being able to effectively challenge these disputes. So it'll be really interesting to see if the appellate court judges have a different view than the lower court and allow this case to continue. Speaking of contract pharmacy restrictions, we've seen additional states advance contract pharmacy access bills, as well as provider reporting bills in recent weeks. Will, can you give us an update on where things stand in the states? There has certainly been a lot of developments just even today, 2 hours before you got onto this podcast.
Right. Yes. It's been a very busy day. And just a couple hours ago, we sent out a news alert announcing that the Oklahoma legislature has approved a 340B contract pharmacy access bill and sent it to the state governor for action. So the Senate pretty overwhelmingly passed that vote by a 40-5 margin shortly at, maybe 5 or so weeks after the House passed that bill by a similarly wide margin. It also contains provisions that would prohibit PBMs and health insurers from differentially reimbursing providers and their pharmacies based on their 340B status. So that's certainly very important development there. And we also pretty recently had 2 other bills go to the state governors, and both of these bills are interesting and that they combine contract pharmacy protections with some reporting elements as well. So those 2 states are Colorado and Hawaii. So the Colorado bill that very recently passed and is going to the governor includes contract pharmacy protections for all covered entities. It includes some reporting requirements for hospitals, and it also includes a couple of restrictions on how hospitals can use their 340B savings, basically that they can't use more than 35% of their savings on things like compensation to the board of directors and lobbying and advertising and PR. So that's a bill that providers in the states strongly backed. There is another somewhat similar bill that had much more significant restrictions on hospitals and stricter reporting requirements. So hospitals did oppose that bill, but supported this current one that has some restrictions, and that is headed to the governor. So that is pretty interesting development there. And pretty similarly in Hawaii, the bill that is headed to that state's governor is one that includes contract pharmacy protections for all covered entities, and it also includes reporting requirements for all covered entities. So what's interesting about the reporting requirements in Hawaii, though, is that they are specific to contract pharmacy use. So there's no sort of overarching questions about total operating costs, total charity care, or total amount of 340B claims like many of these other state laws. It's basically just about, payments made to contract pharmacies for 340B drugs and the locations of out-of-state contract pharmacies. So that's a pretty interesting one there. And part of the compromise that also makes it pretty unique is that the entity responsible for compiling the report is not actually Hawaii's state health department. It's actually the trade group that represents hospitals and health systems in the state. So they will be responsible for putting the report together, which I'm sure hospitals there are happy to have some control over what the messaging surrounding that looks like. So those are two pretty interesting hybrid bills to follow, because we have not yet seen a bill like that has both reporting and contract pharmacy protections actually get enacted. The other two big developments, to follow up on some stuff we were talking about last podcast, is that Tennessee has now enacted its contract pharmacy access law. So the Tennessee one is unique in that it only prohibits drug maker contract pharmacy restrictions that are placed after July 1st. So it grandfathers in all of the existing ones. The reason behind that, according to sources, is the bill got hit with a pretty big fiscal note, meaning that the nonpartisan budget analysis group in Tennessee said the bill would cost a lot of money, most of that having to do with increases to state employee health insurance plans as a result of restrictions ending. So in order to get the bill through, they had to remove that provision. The other bill that passed is in Indiana, where a long-awaited hospital reporting bill did, in fact, get passed. It was widely expected that there was going to be some kind of reporting bill or 340B restriction bill that got passed, a much more strict bill that would have really restricted how hospitals can use 340B savings ended up dying. But this bill that places reporting requirements on hospitals did get passed. The governor signed it, and now it'll take effect. So, as always, a ton going on in the states that we're continuing to follow very closely.
Yeah, thanks, Will. So it sounds like if these states get their governors to sign the bills, we'll be up to what is that? Will be 17 or 18 states that will have enacted contract pharmacy protection bills.
Yep, it's somewhere like that. Like we're very high up right now, and yes, with 3 more awaiting their governors, those are very likely to become bills as well. So it's looking like we'll be pretty soon potentially in a position where more new contract pharmacy access laws are enacted in 2025 than were in 2024, and 2024 already was a record-setting year. So tons of momentum there.
Yeah, and I got a text while we were talking, you may have as well, that there was some progress in Maine as well. So I don't think it means that it's gotten to the governor's desk, but I guess it passed one of the committees in Maine. So that's news to report as we're speaking. Just one comment about the Tennessee bill. To me, it's very puzzling that they say that the contract pharmacy restoration would end up costing is it state employee health plans or is it private health plans? Do you know, Will, what they
Yeah, so it's a lot of health insurance plans for state employees. Yes.
Okay. To me, that seems very puzzling since some of the state employees actually are working at state hospitals that are in the 340B program, and there are partnerships between some of these states and covered entities that end up lowering costs. So I would question the guys who are crunching the numbers there, but nonetheless, interesting development. And with that, before we turn to Shannon and find out what's going on in Washington, let's take a moment to hear from one of our great sponsors.
Maxor, a trusted pharmacy care solutions leader since 1926, improves patient outcomes and reduces healthcare costs through clinically integrated services. From specialty pharmacies to comprehensive pharmacy management, we optimize the pharmacy experience for patients and partners. Backed by deep clinical expertise and a legacy of exceptional service, Maxor delivers unparalleled value in pharmacy care. Learn more at maxor.com. That's maxor.com.
It's also been a busy time for 340B policy in Washington, D.C., with President Donald Trump unveiling his HHS budget plans and congressional lawmakers working to wrap up their own spending legislation. Shannon, what have you been watching?
Yeah, so as Ted mentioned, federal healthcare spending is a hot topic in Washington these days. In Congress, we have Republicans who, in both chambers, who are wrapping to work up a giant, wide-ranging spending bill. And as part of that, they're looking to identify $880 billion in health spending cuts. The bulk of those are expected to come from Medicaid, but how we get to that number, we're still trying to figure out. There's a lot of infighting among Republicans over how they're going to find that much money to cut. There's a lot of pushback from Democrats and health stakeholders over it. And so this is something that's been developing over the last several weeks, will probably remain in flux at least for a couple more months here. The goal for the end bill is by the summer. So we'll see if we hit that target. And as part of those talks, the White House recently put out a proposal for Medicaid specifically that would implement a most favored nation policy for drug pricing, which basically means it would tie pricing for Medicaid drugs to the prices that are paid by other affluent countries as part of an attempt to lower drug prices. The policy hasn't really been super popular. It's drawn mixed feedback from Republicans on the Hill. The drug industry has been very vocal in its opposition to it. And then just healthcare stakeholders, 340B stakeholders have been sort of puzzled by it, expressing concerns and pushback as well. There's been questions as to why they would target this sort of policy at Medicaid, given the different drug price discounts that already exist in that program. And then we had some reports from Politico in the last few days suggesting that the White House might actually pull back this policy, not try to move it as part of these big spending bills, and pursue it on its own as part of a larger executive order to implement an MFN policy for drug pricing that would also include Medicare. And this is something that Trump proposed during his first administration, sought to implement it, and didn't ever really take effect because the Biden administration came in and rescinded that. Ted, do you want to give us a little bit of background about what happened on that MFN policy?
Yeah. And I think my impression, Shannon, is that there was a lot of pushback on the Hill about this Medicaid, tying Medicaid prices to other countries. Perhaps the administration didn't realize that there's already a program in place called the Medicaid Rebate Program. And so there is, it looks like now, if I'm right, Shannon, that this would be likely an executive order related to Medicare, maybe not even Medicaid. Does that sound right from what you're hearing?
Yeah, we haven't seen the full details yet. And Trump himself supposedly hasn't even signed off on it. So it's unclear, but the focus would be more on Medicare, it appears.
Okay, so in the previous Trump administration, they proposed a policy that would have pegged Medicare Part B drug reimbursement for 50 expensive physician-administered drugs on the lowest price that drug manufacturers provide in similar countries. There was a lot of pushback from this for this proposal from all parties. This is one where the drug industry and the 340B community were united in their opposition to the proposal. The 340B hospitals were really happy when the Biden administration decided to kill the proposal because they argued that the drug Part B reimbursement under the model could have resulted in payments of 65% less than an average drug's average sales price. And the drug industry argued that the model would have harmed patients and innovation. So everyone was happy when the Biden administration said no to the that index pricing idea. Sounds like President Trump, from what I have read, is concerned about his polling numbers and wants to do something that he thinks would be embraced by the public. But to be candid with you, I don't think that anything significant will end up becoming ever happening. That is my cynical view when it comes to the efforts by particularly the Trump administration to take on the drug industry. I think it's a lot of talk and not a lot of action. So certainly they will do what they can to try to rein in the 340B program, but I don't think they're going to be doing a lot to hurt the drug industry. Shannon, what else is happening in Washington in the past few weeks?
Yeah, so we also saw on Capitol Hill Senators Josh Hawley, a Republican from Missouri, and Peter Welch, a Democrat from Vermont, announce a new bill that would cap the U.S. retail list price for prescription drugs and biological products at their, quote, average retail list price, unquote, for Canada, France, Germany, Italy, Japan, and the UK. And any manufacturer who would violate that would face a big penalty equal to 10 times the difference between the US list price and the average price for the 6 countries. So it's kind of tackling a similar issue that President Trump has put forward. There are some notable differences here. And also noteworthy is that it doesn't specifically reference the 340B program. However, it, like all of these other things we're talking about, could affect the cost for 340B drugs. It's an interesting pairing here. We've got Josh Hawley, who's known as being very conservative, and Peter Welch, who's known as being pretty progressive. Both have raised concerns about Medicaid cuts, and so this is sort of seen as an area where they're in alignment. And Welch is notable because last year he introduced the Senate version of the Patients Act, which is Doris Matsui's bill to codify providers' ability to use contract pharmacies to dispense 340B discounted drugs. And he's expected to probably reintroduce that bill in the new Congress. And then aside from the drug pricing issue, as Ted mentioned, President Trump released his fiscal year 2026 budget blueprint for HHS, and it called for major cuts, about $33 billion in shakeups at the agency. And that includes at the Health Resources and Services Administration, which oversees the 340B program. However, it didn't provide a ton of specifics, and it didn't mention changes to 340B. That includes details that were included in a leaked document that came out a couple weeks ago that had HRSA moving over to CMS and the 340B program, or not moving HRSA over, moving the Office of Pharmacy Affairs, which is in HRSA, over to CMS. This document that came out, like I said, was pretty bare bones. And so we're still waiting to see what the details are. But, you know, all the tea leaves we're reading suggest that there could be some major changes to 340B.
Yeah, that would be really interesting, Shannon. I know, as you've mentioned before and you've done in your reporting, there's a lot of concern from the 340B community about CMS overseeing the 340B program. They have implemented policies or proposed policies in the past that are perceived by the provider community to be not friendly, including major Medicare Part B cuts, as well as Medicaid reimbursement cuts. And they feel like HRSA is more of an advocate, or at least someone who's more sympathetic to the cause. So it would be real interesting to see if this actually happens. I know some in the drug industry are pushing it hard, and there is some reason to potentially have someone like CMS oversee it, considering the fact that the 340B program does interact very closely with the Medicaid rebate and Medicare programs. So will be really interesting to see whether that happens. Be very different certainly for the health centers, because they are not used to working with CMS. They work with HRSA for all their programs. So it'd be very, very interesting to see what happens there. So with that, I know we covered a lot. I want to thank you all for your excellent reporting and hard work. I know you're all really, really working hard these days, and nothing ever slows down in the 340B world. Perhaps this summer in August, things will quiet down when Congress goes away for a little while, but I'm sure we'll keep busy. With that, we'll keep an eye on things, and we'll be back in 2 weeks. And of course, we'll report on anything that happens in the coming days. And please follow us for our twice weekly issues that come out each Tuesday and Thursday. And with that, we'll wrap up, and thank you for joining us today.